I think it's very similar to how you would do it, any medication choice for a patient. So first thing is the baseline characteristics of a patient, right? Do they have other comorbidities? Because let's say the two are quite different and have different side effect profiles. So you want to first look at that. So for instance, if you're doing apomorphine subcutaneous injection, that might have a little bit more susceptibility to hypotension and nausea factor. So if someone's already hypotensive, like many of our patients with Parkinson's, then you probably wouldn't go for that one. But let's say a patient has a comorbidity of COPD, you're probably not going to go with inhale levodopa powder because they probably can't inhale it, right? So that's I think one key factor. Of course, you also have patient preference. Maybe patients are needle phobic, or maybe patients, honestly, they can't get over the administration side effects. So I think the number one thing is patient choice. First of all, I think I get a lot of needle phobic patients, so that's an easy off the bat. And then again, like their comorbidities as well. I think the key thing is that we know all of our oral medications, of course, then it's the gastrointestinal dysfunction. So, of course, seeing how they're delivered, they bypass the GI tract. That's a huge thing. I think one of the most interesting studies was the open label study for the morning akinesia. That's huge. We don't have a lot of stuff, actually hardly anything that helps that, right? We always tell our patients I actually tell my patients, just put your first pill on your bedside, and as soon as you get up, just reach over and swallow it. But again, you have the gastrointestinal dysfunction. So the study with the morning akinesia was very helpful and great for us clinicians to know that there is an option for this very tough symptom that patients experience. For the inhale levodopa powder, I think it's a little bit easier to use because you don't have to do a needle, and I didn't kind of make a joke that it's kind of similar to smoking, but it kind of is. When I've seen patients do it, I'm like, it kind of looks like that. But I think the ease of just the use of that, and you see the improvement in the UPDR score quickly within 10 minutes, or both are within 10 minutes, but I guess that's the other point, is both of them show that Tmax concentration within 10 to 20 minutes is a big factor for wanting to use these, on-demand therapies for off times. I think education, and setting the expectations. Like, so for instance, if you don't tell a patient that they might have the cough issue with inhale levodopa powder, they will, when they first encounter that cough, first they're going to do it wrong, right? They're going to assume it's like any other inhaler that they've seen, like asthma inhaler, where you take a big puff and they'll cough it all out. So not only one, do they have the side effect, two, they're going to cough it all out and not even get the therapeutic effect of the medication. Same thing with apomorphine. I think if you set the precedent that yes, there's a possibility you can have hypotension and the nausea, especially because there's no current antiemetic therapy that we can give to counter that. At least if they know about it and it happens, they're not going to be completely caught off guard and then choose to discontinue either of the medications. So setting good expectations, educating the patient what could happen, and if it happens, it's okay. It's not going to be permanent. It's going to be very short and brief and mild to moderate, I guess, based off of clinical trials. You'll get over it, and if you don't like it, then you don't have to do it again. So that's the first part about it. And luckily the companies also, I think they both send nurses to the patient's home to educate them about that as well, and to help them administer their first couple of doses. So hopefully there's that continuity of care that they can do. Honestly, from the get-go, based off of all the clinical data that we have now, the preference is showing that ER formulations are much preferred, right? I think that all the data is suggesting that, unfortunately, even though IR levodopa is great and cheap and effective, long-term use of this volatile pulsing of the medication is going to cause issues for a longer period of time. And we definitely see that with our patients who've had long-standing Parkinson's, where we feed into the motor fluctuations. And so I think presenting patients, hopefully with that data, if we can, we should start them on an ER formulation. But let's say they are on an IR formulation. Therefore, then when they start experiencing these motor fluctuations, because we know it's a question of when, not a question of if, that for sure is, if accessibility wasn't an issue and cost wasn't an issue, for sure that, as soon as they start experiencing motor fluctuations, we should switch to an ER formulation if possible.